Our next neurologic disorder is going to be strokes. So cerebral vascular accidents, they are also called brain attacks, stroke, it's all different words for the same thing. It's a lack of blood flow supplied to the brain, which is causing symptoms for our patients. So we're going to be looking at 3 different presentations for stroke. One is hemorrhagic, the other is occlusive, the other is a TIA, or a transient ischemic attack. So the pathophys of a stroke is that, and here's all the different, same terminology, is that the part of the brain tissue is deprived of oxygen and glucose, meaning that that tissue is starved for nutrient, meaning that tissue is dying. One of the common things we say, just like with heart attacks around strokes, is time is tissue. So we always want to know, when was the last time that patient was neurologically normal or intact? When did they not have symptoms? It's a big part of our diagnostic and treatment. For the etiology of strokes, we're talking about either occlusive, meaning a blood clot has formed, or there's some reason that circulation can't reach the cerebral tissue, starving it of oxygen and glucose nutrients. Hemorrhagic, meaning that the blood supply to the brain has ruptured and that there's active bleeding into the cerebral tissue, which deprives neurologic tissue downstream and locally around the bleeding of appropriate nutrient supply and blood flow. And then temporary are TIAs. So these present, their symptoms are exactly the same as having a stroke, but the etiology or the reason that they're having them, we don't quite know. Sometimes we refer to these as pre-strokes. So sometimes they may have like a partial blockage of one of their cerebral arteries that every now and then doesn't allow sufficient blood flow through, and that can cause a temporary presentation of stroke-like symptoms. Some of the other things we want to pay attention to for etiology are both modifiable and non-modifiable risk factors. Things like age and gender. So advanced age, 60 or greater, males are more at risk than females. And then family history is also a big deal. Do they have family members who have had strokes? Modifiable risk factors, hypertension, especially uncontrolled hypertension, is is much more correlated with like hemorrhagic strokes because we have disorders of pressure. So long-term exposure to pressure can expose underlying weakness in the vascular system. Arrhythmias, so things like cardiovascular dysrhythmias like AFib, or some of our valvular disorders that cause turbulent blood flow, increases the risk of clots forming in the circulatory system, which can predispose patients to occlusive strokes. Smoking and alcohol use, it's nursing school, they're the root of all evil. They do cause sclerotic abnormalities in patients, so we do need to watch out for both occlusive and hemorrhagic strokes in those types of patients. And hyperlipidemia. So we're used to talking about hyperlipidemia in terms of like heart attack risk, but those atherosclerotic, the word I can't say, the plaques in the coronary arteries, those plaques don't just form in the coronary arteries. They form in all the arteries, leading to peripheral vascular disease if they're distal, or they can lead to partially occlusive areas in the brain, which is part of what we attribute TIA presentation to. So here's kind of what those different ones look like. So ischemic strokes, there is a blood clot or a plaque that completely occludes blood flow to a part of the brain, meaning that all of this area downstream of wherever that occlusion is, that blockage, becomes anoxic. Anoxic meaning lack of oxygen is being provided to those structures. And because neuron tissue does not store glucose or oxygen as part of ATP production, these cells start to die pretty quickly. So this is kind of what that thrombic presentation looks like. Hemorrhagic, similar except bleeding. So when those arteries get broken, bleeding occurs into the cerebral the cerebral tissue, leading to impaired circulation downstream and an increase in pressure around the area of bleeding. The pressure is a big problem because of the skull. The brain can't swell, so the only option is to increase internal pressure. It's almost like a compartment syndrome type thing. It can't get bigger. All it can do is get denser and have more pressure. So That's a big problem, especially when it's your brain. TIAs, sometimes they call them mini strokes, but what we think is going on here is that there's an area where blood flow is temporarily or partially blocked, leading to downstream kind of neurologic deficits. It's more like our partially occlusive or temporarily occlusive type of a stroke. So visually, those are what the three different types look like. For our stroke assessment, super, super important because part of the reason we diagnose stroke is based off of physical exam. There's typically or traditionally a contralateral symptom presentation, meaning that if the stroke is on the left side of their brain, the symptoms we're going to see are on the right side of their body. Alternatively, if the stroke is on the right side of their body, the presentation of physical symptoms will be on the left side of their body. I think I said the words wrong there. Right side of the brain, left side of the body, left side of the brain, right side of the body. Kind of the way that works. That's what that contralateral means. One of the exams that we do is our FAST exam. Things we're looking for, the symptoms that they're going to present with, facial asymmetry, meaning part of their face will have normal expression, the other side will be paralyzed. Arm strength asymmetry. So if we ask them to raise their arms, one side will go up, the other they won't be able to move, or they'll have neurologic, deficit. Speech impairment, it's kind of like what I'm probably having strokes while I'm presenting this stuff to you guys, which is why words are so hard. But speech impairment, they can have difficulty forming statements. They can also have inappropriate use of words. So they'll say things like lettuce is happening right now. They put the wrong word in a sentence. So any kind of speech impairment is also a thing. They may also lose the ability to speak. And then time is for the T. When was the last time they were normal? Which helps us get to when did this event happen? Did it just happen 20 minutes ago? Did it happen 4 hours ago? That kind of thing. CNS depression is also a common symptom with strokes, especially very, very large strokes. So where a large portion of the brain is deprived of circulation. So our FAST exam also represents some of the symptoms our patient's going to present with. Loss of visual field, also a thing. So these patients, because they have this stroke that's affecting their brain, they're going to lose all of their left-sided kind of visual field or all their right-sided visual field, which affects both eyes, which is really kind of trippy to wrap your head around. So they'll not just lose things over here, but they'll also lose things in the middle if you're covering one eye versus the other. So we always assess individual field of vision for each eye, not just their general presentation. And aphasia, we talked about this a little bit, which includes difficulty swallowing. Because these patients have had neurologic injury that is impairing their ability to speak, we need to be very, very careful that these patients can also swallow appropriately. Do they have the neuromuscular capability of organizing contents in their mouth and swallowing them into their esophagus, not pushing them into their trachea, leading to aspiration? So that difficulty swallowing, big, big concern. And the difficulty speaking and understanding what they're saying, also a concern that we see as part of the assessment. So when we start looking at all the signs, here's all the symptoms that we can see. The presentation is very, very different depending on where in the brain their stroke is happening. So a lot of these things we want to look out for, but the big themes here are we're looking for unilateral presentation of symptoms, meaning the left side of their body is different than the right side of their body, and that contralateral presentation. So what we see going on in their head is different from everything going on from the chin down. So that contralateral presentation of symptoms is what we're looking for. So here's kind of some generalized, if they're having a left-sided stroke, here's some different areas that they may have. If they're having a right-sided stroke, right and left side of the brain do different things. They focus on different problems that the body solves on a regular basis. So they're going to have different symptoms. Our left side of our brain tends to be more like analytical, so math might be a hard thing. Coming up with like appropriate linear answers might be very difficult for these types of patients. Patients with right-sided brain damage, they're going to say like, I can't feel my left side, I can't move my left side. Their deficits are going to be very different than a left-sided CVA. So we are always looking for that contralateral presentation. Symptoms also depend on the location in the brain. So we know the three general structures of the brain. We've got our brainstem, cerebellum, and cerebrum. One of the big problems, the most severe type of stroke that a patient can have is a brainstem stroke. Reason for that controls all our autonomic functions, things like heartbeats, breathing, spontaneous ventilation, things like that. So those are our most severe level of strokes. Patients with cerebellum strokes, it's a motor control, coordination type thing. So they're going to have difficult times with movement. Cerebrum strokes, it's all the cognition, all the things that go on in the body. So depending on where the stroke is in their brain, they're going to have very different presentation. But our brainstem is the most severe type of stroke that a patient can have. So here's kind of a dermatome map of the brain, showing like where different regions of the brain control different things going on in the brain. And this is just kind of a slice. So if a patient has a stroke in this region of the brain, we're going to see symptoms that may range from the fingers to the thumb. So hand type presentations. If it's down this type of the brain, it's going to be more oral. So that's kind of what we mean by where in the brain very much depends on what type of symptoms we're going to see for our patients. For medical diagnosis, a stroke is a medical emergency. And one of our first priorities is we need to figure out what type of stroke this patient is having. So for assessment, first physical presentation to identify, is this person having a stroke or are they just like being weird? We just don't know, so that's what we're looking for. We're looking for that fast exam. Facial symmetry, musculoskeletal asymmetry, so arm asymmetry, speech, and is this a new thing or is it a long-term problem? So the timing. And then looking at risk factors, do they have uncontrolled hypertension? Things like diabetes, big risk factor for hemorrhagic stroke, obesity, those types of things. Birth control for younger people, younger women, should be more specific with that, because of the risk of clotting associated with a lot of birth control medications. And then we do NIH, National Institute of Health, Stroke Scale scoring. So this is it's a standardized exam that usually the only nurses that get trained on NIH Stroke Scale is staff members that work on a neurologic unit where they're going to be caring for stroke patients. It's not part of general training that all nurses receive. So if you're going to be working in an area where stroke scale is happening, you're going to learn the NIH Stroke Scale. Here's a link to a physician doing a stroke scale on a patient, and this is like the most awkward human ever. So it's kind of entertaining if you're looking for something to kind of really make you laugh at somebody trying to do a physical exam. It's a good one. So the first diagnostic thing we do is a CT scan of their brain, because the most severe version of these strokes is hemorrhagic. We want to make sure they're not bleeding into the brain, which is going to cause an increase in ICP or intracranial pressure, which if left untreated will cause brain herniation, meaning the brain will squeeze down through the magnum foramen and the brainstem will herniate into the spinal column, which is a life-threatening, it's a very fatal disorder. Most patients don't recover from that. So we always do a CT scan first to rule out a bleed or rule in a bleed, but we're always looking for a hemorrhagic stroke first. So have they had any trauma, a subarachnoid hemorrhage or a subdural hemorrhage, meaning like what level of the cranium into the brain is bleeding. So trauma is also a reason patients can have stroke, so head injury, also something we want to look out for. Then after CT, then we'll do an MRI to determine the extent of cerebral tissue damage. And we'll do this for both hemorrhagic and occlusive to look at that damage afterwards. But for hemorrhagic, the treatment is very different because we have to relieve the pressure on the brain. Excuse me, the MRI will also be used after their stroke, during their recovery, to anticipate what their prognosis may be, what the level of return of functioning looks like versus what's going to most likely be a long-term complication or symptom that they'll present with as a result of that cerebral tissue injury. So the nursing diagnoses, the things that we're going to be worried about when we take care of these patients. One, disturbed body image, because these patients they're not going to be able to have sensation on half of their body. So they're not going to know it's there, they're not going to be able to control it very well, which can mean they feel really weird about it. They have to pick up their arm to move it places. So disturbed body image is absolutely a thing. Fear, absolutely also, because they're going through an acute life-threatening emergency, and because their world is totally different. The way they navigate the world will be forever different after a stroke. Risk for falls. This is a big one because patients don't know their limitations after neurologic injury. So we always need to pay attention to their risk for falls. And risk for acute confusion. The acute confusion in that immediate new onset stroke presentation. So we want to look out for those things. These address a lot of the psychosocial components of having a stroke because we've kind of covered the physical stuff quite a bit. So the medical plan. So if patients have a hemorrhagic stroke, it's by far not the most common type of stroke, but it is a very, very severe one. This one will kill patients the quickest because of that increased in intracranial pressure. These require neurosurgical repair. So the first line of treatment is we have to eliminate the pressure. So a neurosurgeon will put in what's called burr holes in a patient's skull where we can relieve the pressure caused by that bleeding in the brain. So we will put holes in the skull to relieve that pressure. So if they have a hemorrhagic stroke, the CT scan that we do immediately is going to be positive. We will be able to see that bleeding into the skull. So that's how we'll know there's a hemorrhagic stroke. If patients have an occlusive or ischemic stroke, this is our most common presentation. What we want to do for these patients is if we can get them to treatment very, very quickly, meaning the time between onset of symptoms and presentation in a care environment is very narrow, then we want to give TPA, which is a thrombolytic medication. It's a clot buster. So we give this medication, it's going to dissolve any clot that's in the body. Our hope is returning blood flow to the brain and minimizing long-term tissue damage so the patient can have a full and quick recovery. For these patients, their MRI will be positive. The CT will be negative. We won't see bleeding in the brain, but their MRI will be positive because we will see that tissue damage from the deprivation of blood flow. For TIA, both of these are going to be negative. So the CT of their head will be negative. We're not going to see bleeding. And the MRI will be negative. We're not going to see large lesions in the brain that are dead tissue because they've been deprived of circulatory blood flow. So symptom support is a big, big thing for TIAs because we're just kind of waiting for symptoms to resolve to see what's going on with these patients because physically we don't see anything abnormal that's going to have a long-term effect on that patient. If we've ruled out an occlusive or hemorrhagic stroke and a patient is still presenting with stroke-like symptoms, a lot of times we're going to call that a TIA. So it's kind of our diagnosis of last resort. Pharmacologically, the plan is going to be antiplatelet agents. These are going to start in the hospital where we'll be giving things like IV heparin to prevent further exacerbation of blood clots, but they'll also continue as an outpatient where patients will be on Plavix and aspirin to prevent blood clots in the future and lower their risk of having a stroke after their initial presentation. And also lipid-lowering agents like statins to help with the hyperlipidemia that can contribute to an occlusive stroke. Surgical interventions may be necessary. They are necessary for a hemorrhagic stroke, but they may be necessary for an occlusive. It just kind of depends on what's going on. For hemorrhagic strokes, we talked about the burr holes as that immediate procedure that's going to be done to relieve the cerebral tissue pressure. The other one is an endarterectomy, which is kind of like a PCI type procedure where they're going to try and repair the blood vessel in the brain so that they can restore normal blood flow and kind of prevent bleeding into the cranial space. They can also do endarterectomies for severe occlusive strokes to try and reopen a blocked cerebral arterial pathway. It's similar to cardiac PCI, where they're going to inject that dye to visualize the full vasculature of the brain and look for areas that don't get adequate circulation when that dye is injected. And then they'll navigate their equipment up into those spaces and potentially use stents to reopen, or some other type of stents that are occlusive to try and repair part of the cerebral arteries. So those are kind of our surgical options, but they are some of those minimally invasive type procedures. They're not going to have full open brain surgery for stroke. It's going to be those minimally invasive PCI type interventions. Here's what here's like a clot in here. This is in the carotid artery, so right up in here. Carotid stenosis is a big risk factor for stroke. Carotid stenosis, meaning these plaques are forming in the carotid arteries, which is a big risk for blood clots, which will directly cause, if those break off, they go directly to the brain and will lead to an occlusive stroke. So one of the places we look is not just in the brain, but also in the carotid arteries to make sure that that's not the source of where this clot is coming from. Lots of patients who have occlusive strokes, the etiology of that problem isn't necessarily in their heart, or it's not like a random clotting disorder. It's usually from these carotid type of disorders where it's going straight to the brain after that clot has formed. So the nursing plan, one is medication education, especially in the early phases around some of those antithrombic medications or the thrombolytic medications and some of the anticoagulants that they're going to need to be taking long term, because compliance and complications is a big deal. Patients need to be taking their antiplatelet agents all the time, every day for as long as they're prescribed by a physician. So compliance is a big deal because if they don't take those antiplatelet agents, they're at risk for forming a clot, which could lead to another stroke. So complications of these, we want to look for, one, around compliance. If they don't take it, are they having signs and symptoms of stroke? Two, are they taking too much, meaning they have signs and symptoms of bleeding? So patients who have an occlusive stroke and are started on antiplatelet medication are also at high risk for having a second hemorrhagic stroke from these antiplatelet agents. So we do need to be very careful and make sure patients always know how to do a fast exam on their family members and when they need to come back to the hospital, which is anytime those symptoms come back. Also, our big plan is how to prevent harm. So keep our patients safe while neurologically they have damage. So things like airway protection, so ABCs, right? Airway protection, big deal. Swallow evals are the way that we do this. Every patient that comes into the hospital where we're ruling out a stroke is NPO until proven otherwise. And proven otherwise means that a speech therapist needs to do a swallow evaluation to make sure that neurologically that patient is able to coordinate and swallow any contents in their mouth appropriately and not aspirate on that content. So these patients are going to be NPO. Communication support is also a big thing. In the acute phase, where patients first present with a stroke, they may not be able to communicate effectively. So we may have to find other ways to communicate with these patients. That could be they have to write things down with maybe their left hand instead of their right, maybe their right hand instead of their left. We may have to do things like, can you blink twice for yes, once for no, kind of things. So we may have to find other ways to communicate with our patients other than verbal. this can be very frustrating for patients because typically when they have these communication deficits or cognitive impairments around how they physically present themselves, cognitively they are completely intact. So they're A&O times 4, but they can't manifest that outwardly. Inwardly, they're just kind of suffering in silence in their own head, not understanding why the rest of us aren't understanding them appropriately, which can lead to some emotional lability, a lot of frustration. Patients can get very angry very quickly. Other things we want to look out for when we're planning. If our patient has a hemorrhagic stroke, their symptoms are going to get worse over time. Right? So how they first present when we start taking care of them is not how they're going to be in, say, 5 or 10 minutes. They're going to have more symptoms as time goes on, because as that bleeding continues, they're going to keep having more tissue damage to greater areas of the brain, larger areas of the brain, and their symptoms are going to get more severe. For occlusive or ischemic strokes, their symptoms are going to start immediately and they're going to be stable. So as we do that Nih Stroke Scale every 30 minutes on a patient, if they're having a hemorrhagic stroke, their score on that scale is going to change. If you're doing a fast exam on a patient, they're going to change. The level of injury that patient has is going to change. If they have an occlusive stroke, their fast exam or their stroke scale exam, they're going to score the same, or their assessment will be the same over a period of days as we're doing those exams. So they're not going to change. For TIAs, the onset is going to be immediate, just like all of our other strokes, but the symptoms are going to reverse over time. So when we first start assessing these patients, they're going to be the most physically limited of that disease kind of presentation. Over the next 48 to 72 hours, their symptoms are going to get better until they return to more normal or fully normal, what their baseline was before they came in. They may still leave a care environment, a hospital, before full return to baseline, but they're always trending towards full recovery of neurologic and motor function. So for implementation, the way that we do this is most facilities have what's called a stroke alert. This is an overhead announcement, stroke alert in 5 minutes, because the paramedics who are bringing a patient into the hospital are calling ahead saying, we suspect this patient is having a stroke because they have a fast exam that shows this or something else like that. This is a stroke protocol. This is what's going to happen. And the key thing here I want to leave you guys with is a lot happens really fast. So here's how this goes. Within 10 minutes of the patient coming in the door to the facility, a physician is going to perform an assessment, a fast exam, and we need to plan for that CT scan to be done. An inpatient stroke alert is called overhead to notify everybody that that's going to happen. So 10 minutes, examine them, and start getting them ready for that CT scan to rule out a hemorrhagic stroke. Within 15 minutes of coming in the door, a neurologist is going to examine that patient in addition to the physician that did the initial exam. And that patient will have had their CT scan or going to their CT scan within 15 minutes. Within 25 minutes of arrival, the CT scan was going to be completed and the results are going to be read by the neurologist that just assessed that patient. So 25 minutes, CT scan done, neurologist has read it. And we need, as nurses, our role here is we're going to start preparing this patient to go to the ICU. No matter what. If they're having a hemorrhagic stroke, neurosurgery is going to happen, requiring ICU. If it's an occlusive stroke, they're going to be getting TPA, that thrombolytic, which is also in the acute phase. It's an ICU level intervention. So we need to prepare this patient to do that. Here's the big deal, why we need to do this so quickly, is within 60 minutes, if they're having an occlusive stroke, TPA can be given. If it's greater than 60 minutes, most stroke policies, stroke alert policies, do not allow TPA to be given because the risk of causing a hemorrhagic stroke is too great after an hour of tissue death, right? Because the arterial tissue is also dying distally to the occlusion. So we don't want to break it open, rush some blood in there, and then cause a hemorrhagic stroke. So that's why time is such a big deal, is because after an hour from symptom onset, we lose one of our treatment options, which is that thrombolytic TPA medication if they're having an occlusive stroke. If they're having a hemorrhagic stroke, they're going to be in the OR having those burr holes done, having that vascular correction done within 60 minutes. So post-acute implementation is also something we need to pay attention to. So after that initial stroke alert in the emergency area, when we're taking care of these patients in the acute care phase, we're going to need to focus on some different things. So things like acceptance of their deficit. So we want to set our patient up for success. This can include environmental things. Particularly, don't approach a patient in a part of their visual field where they've lost visual acuity. Remember that picture earlier where the patient had lost kind of on both eyes part of their visual acuity? Don't ever approach a patient on the side where they have a visual deficit. Always approach them from the side where they have normal eyesight. Otherwise, you can terrify them. Like, when people sneak up behind you and tap you on the shoulder, it can be really startling and terrifying. Make sure we're not doing that. Also, their physical environment. We don't want to put things like a call light or their bedside tray on a side of their body where there's a deficit. That can actually be considered a restraint. If we put their call light next to their paralyzed extremity, they have no means of calling for help. So that can be a problem. So physically, we need to manipulate the environment so that their affected side is not the side that they have to rely on to call for help or to eat food, those sorts of things. So we may need to set things up for the side of their body that is still working appropriately. Also communication. So we know that a lot of the times, cognitively, these patients are intact. So neurologically, in their brain, they are A&O times 4, but they're not able to express that because that's where the stroke is affecting them. So they may not be able to functionally speak to the level that neurologically in their brain they are. So we may have to use alternative ways of communicating. Blinking for very severe injury, communication boards, either with handwritten with the other extremity, or those boards where they can point to letters to form words and statements can also be used. It just depends on the severity of their stroke. But we definitely do need to pay attention to that and look for those alternative communication methods and really meet our patients where they are in terms of their disease presentation. Vital signs monitoring, also a big deal. Things that we anticipate in the immediate kind of post-presentation phase: elevated heart rate, elevated blood pressure. When the body has a stroke, it naturally gives the patient a very high blood pressure, like 200 over 100 for about 48 hours after the stroke. So initially they may have very, very high blood pressure. We don't want to keep that going long term, but in that immediate post-stroke phase, the body is really trying to perfuse its brain. So it's increasing pressure, trying to increase perfusion. So we may allow that patient to run much more hypertensive than we would another patient in order to try and perfuse the brain as much as possible. This is, obviously we don't do this for our occlusive strokes because it's already ruptured and that's going to make it worse. But for our occlusive strokes, we do tend to let them run a little bit high on their blood pressure. So around 220 is kind of where we go if they haven't gotten TPA, so that clot busting agent. If they've had TPA, we do not let them get that high because we don't want to cause a rupture, which will then bleed. We don't want to give them a hemorrhagic stroke, so we don't tolerate quite as high of a blood pressure, but we do still let it go quite high in the short term. Usually after about 48 hours, we start treating that hypertension to bring it back down into normal parameters. But in the short post-acute phase, we do allow them to run high on their blood pressures to try and improve recovery, cerebral recovery. So for the evaluation, first and foremost, the thing we want to teach our patients, symptoms. What are the signs and symptoms of a stroke, and how can they recognize them in the future? If you've had one stroke, you're at very, very high risk for having another. So we always, just like with heart attacks, want to make sure patients know what to do if they have another stroke. This includes fast exam teaching, not just to the patient, but also to their family, the people who are going to be around that patient to call 911. We want to make sure they can do that fast exam. Also medication teaching, especially for compliance, because we don't want them to not take their antiplatelet agents, which can increase their risk of a second stroke. And risk factor teaching, controlling their blood pressure, controlling their hyperlipidemia, so taking statins, decreasing high fat, high cholesterol foods, mitigating their risk factors, not smoking, not drinking, really limiting those things that we know will cause or place patients at a greater predisposition for having a second stroke. So here it all is in one big picture. What we're doing with CVAs or strokes, things we're looking for. We're looking for all the symptoms. If you want it all in one place, here it is. But our goals, airway, oxygenation, and decrease their ICP, right? Rule out hemorrhagic first, then treat occlusive. If both of those are negative, then we have a TIA, and we're going to do symptom support. So always make sure they're not bleeding into their brain first and foremost. If they're not bleeding into their brain, then we know they've got an occlusive stroke, and we're going to deal with increasing cerebral perfusion as much as possible. So that kind of permissive hypertension for a short period of time. That's all we've got for strokes.